Good evening, Reena ma'am.
Good evening. All set?
Yes, ma'am.
Okay, I think the others will join shortly.
Yes, ma'am. We'll start 6:30
Yeah,
exactly.
at one time. Yes.
Okay.
Can I just share my screen and see if I can get my slides on?
Yeah, sure, ma'am. Please.
So it says you cannot start screening while other participants are sharing.
Yes, ma'am. Please share.
Okay, that's fine.
Yes, Anupama ma'am. Sorry, ma'am, your voice is breaking. You're not audible properly, ma'am. Good evening, Srinath sir.
Good evening. Hi.
Good evening, Amisha.
Good evening.
So
Uh,
welcome to
I forgot we have 3 more minutes. I will send you my slides also. मैंने रीना मैम को तो भेजी थी कि अगर बाय चांस मेरा नहीं अच्छी तरह से हुआ तो यू कैन टेक ओवर।
ओके सर, फाइन सर।
अभी मैं जस्ट 1 सेकंड में भेजता हूँ।
जी सर।
Hi, Amish. We'd like to see you also. Why the mask?
अरे मैम आज ही पता चला कि एक हॉस्पिटल जहाँ पे मैं जाता हूँ 2 डॉक्टर्स हैड कोविड एंड 1 पेशेंट हैड कोविड। तो आज से ही मास्क पहनना शुरू किया मैम। क्या अभी नया चालू हुआ कोविड का।
Okay.
बट एंड आई रियलाइज के वेबिनार में तो नहीं होगा मुझे।
Yes, I wanted to tell you your answer. We'll start on time. There are still 2 minutes. You can send your slides.
हाँ नहीं बस भेज ही दिया मैम मैंने। Sent and somebody can check and I'm ready whenever ma'am is ready.
Should we just give Dr. Hari a call?
Ma'am, shall we start?
Yeah, we can.
Okay, ma'am. Let's start. Good evening, everyone. A very warm welcome to all our distinguished faculty members, delegates, and participants joining us today, IAIO. It's my pleasure to welcome you all to today's IAIO Expert Insight session on Hemato-Oncology. I'm Subhashi, host for today's scientific program. Before we begin, it's now my privilege to introduce our esteemed program director, Dr. Reena Nair, is the senior consultant and head department of clinical hematology and cellular therapy at Tata Medical Center, Kolkata. Ma'am, thank you for joining us for leading today's academic session. I now request Dr. Reena Nair to kindly deliver the introduction and set the context for today's scientific program. Over to you, ma'am.
Thank you. I'll just share my slides. And while I share my slides, there is a disclaimer. I used to be at the Tata Medical Center. Now I have retired and I am very much leading a happy life. So I have my own oncology opinions as a consultation, but I'm not at the Tata Medical Center, Kolkata. But a lot of what we will discuss today is what we have done over there. And of course, we will have the options from people across. For some reason, it says you cannot start the sharing. So can you help me with getting my slides onto the?
Yeah, sure, ma'am.
Okay, got it. I think you'll be able to see it now.
Okay, ma'am.
So we'll start.
Yes, ma'am, please.
Okay, good evening, everybody. With the disclaimer that I have already made, today is a CME, that is kind of a virtual CME, which is organized by the International Association of Integrated Oncology. And it does two things. It helps the faculty to read up a little bit and to actually present their own experiences to the next generation of students who perhaps learn from us. But it helps on both sides of the table or the chair, as I will put it. For today, we have decided we will discuss the invasion of myeloma with immunotherapies. And generally, we have a lot of discussions of therapies that are available and experiences of people from across the world. For today's CME, we are very fortunate that we have had these drugs for some time, and we have two very expert people who will discuss their own experience, one using the BCMA BiTEs, and the second using the indigenous CAR T, which is the BCMA CAR, as a principal investigator. So I of course will just do a introduction, which is to say that there are endless possibilities, but then why the need for new possibilities? And that is the BCMA treatments. Dr. Srinath will actually discuss his initial experience with the bispecific antibodies, the BiTEs in this case, which is BCMA CD3 antibodies. And Dr. Hari Menon, who has been the principal investigator both in the phase 1 and the phase 2 trial of the indigenous CAR T, will discuss his experience in going through an early phase trial and areas where we have a few problems which we need to solve. As you go through their presentations, we will realize that there is a lot of toxicities which are different from the way we have managed chemotherapy toxicities. And Dr. Amish will moderate a panel discussion where Dr. Srinath and Dr. Haribanan will actually maybe give us more insights into the toxicities which they have seen, and maybe also those which we haven't seen, but we can always have a discussion depending, which is available from literature. I don't want all of you to think that this is the only treatment at the end of this CME session. And so we will have a question answer session, which will be moderated by Dr. Anupama Borkar. And please feel free not only to ask questions on these new immunotherapies which have invaded our armamentarium of treatment, but also if you have any other questions regarding the management of patients with relapsed refractory multiple myeloma. So with that, I will do a small presentation to introduce this topic, and then we will go on to the actual experience sharing on BiTEs and the BCMA CAR T cells. So the myeloma treatment paradigm has been sorted for quite a long time. We all diagnose the disease, we risk stratify, and then we take a decision whether this patient is high dose chemotherapy and stem cell transplant eligible or it is ineligible. For patients who are eligible, we give an induction therapy to bring them to the best remission and then consolidate them with high dose chemotherapy and rescue with an auto transplant. Following which they are put on maintenance, either single agent or a dual agent maintenance, depending on their risk stratification at diagnosis. For patients who are ineligible, we prolong the induction to cover the induction and consolidation periods or till toxicity comes, and then we continue their maintenance therapy. But by and large, we know that at the end of therapy, at some point, maybe at a median of 5 years now, unlike earlier when most patients would relapse within a year and a half, we still see recurrences in most of these patients. And so if you look at any guidelines, the treatments for frontline are pretty standard. You have patients divided on the eligibility of their stem cell transplant option, and then you give induction, whether it's 3 drugs or 4 drugs. You consolidate with a high dose melphalan and then put them on maintenance, either a single agent, most commonly lenalidomide, or you put them on double drugs for maintenance. For patients who are ineligible, we continue the induction for a longer period of time. When they achieve a reasonable remission, we put them onto maintenance. But the second line options are very difficult to choose. So we have lots of treatments available and we look at lots of parameters in the patients. Generally, these parameters are what have these patients received earlier. And if we look for options after bortezomib and uh, uh, basically a proteasome inhibitor and an IMiD, then we look at the sensitivity or the refractoriness to lenalidomide and bortezomib or to both before we take a decision about what is the treatment next. If we look at patients who have received DARA-based therapy, then again you look at the sensitivity or refractoriness of the other treatments which they received during their induction and maintenance, and then try to use drugs which have not been used earlier. And again, if you've used all four drugs upfront, then things become a little difficult and we start looking for newer therapies in these patients. So there are lots of trials which have shown us the difference between three drug combinations and two drug combinations in maintenance. And there has been an improved progression-free survival. In many of these trials, to some extent, it has also been doubled. The best results that we have seen is for patients who have received daratumumab-based therapies because the PFS has not only doubled, it has gone up significantly, and it has significantly increased the number of patients who go on to MRD negativity. And so perhaps if the patients have received or not received DARA, when they relapse, if you want a prolonged period of remission, then this is one possibility that is available to us. But are we really happy with these possibilities? Because if you look at the survival curves of PFS, even after transplant, these survival curves continuously come down. And at the end of 48 months, they are almost at the baseline. However, the NCRI myeloma trial for relapse has established that doing a stem cell transplant as consolidation is a good option for patients in their first relapse. And this is a large randomized trial where these patients receive PAD as reinduction, and then they were actually randomized to melphalan and salvage AST versus continuing with weekly cyclophosphamide. There was a reasonably good improvement in the time to progression, in the progression-free survival, but the overall survival was not statistically significant. And the response rates were moderate despite the fact that these patients have received high-dose therapy. So what is the real world data of patients who have relapsed after their first line of therapy? And this is a large real world outcome in patients who are triple class exposed. Population of almost 250 patients in this prospective data from 75 sites across Europe and US. The highlight is that it represents one of the most heavily pre-treated patients with poor prognosis in the relapsed refractory setting. And the thing that is most unique is perhaps the fact that prospectively 91 different regimens were used, which actually reflects the fact that there is no standard of care when a patient relapses. Most of these regimens were carfilzomib and pomalidomide based at that time, which form almost 40%. More than 60% of these patients actually received more than three drug combinations. But at that point of time, the BCMA targeted therapies were available only and given to only 2.8% of the patients. So this particular treatment in this prospective period is considered as the line of treatment as the index line of treatment. Again, if you look at the median time to progression, it's about 4 months. And most of the patients, 90%, discontinued the therapy because of progression. The effectiveness is moderate of all these uh, patients, and the PFS is at about 4.6 months. That's the only thing that I want you to remember from this slide. It's a very busy slide. If you look at the forest plot, almost nothing really matters except the fact that if they are not triple class refractory, then perhaps they do well with whatever therapy is given in the first line. However, the survival curve continues to come down and reaches the bottom line by the 30th month. So the subsequent line after this index line of therapy was given to 60% of the patients. Not all of them got this. At this point of time, the newer drugs seem to have entered the market, and almost 40% of them were given BCMA targeted therapies. And if you look at the PFS2, then from 4.6, we have moved to 10.8 months. And these are heavily pretreated patients. So it appears that a different type of therapy is going to make a difference. Just sequences and combinations of the old drugs perhaps will not improve the outcomes in these patients. At the end of the slide, if you look carefully, the progressive disease is now at about 67%, not above 90%. But what is important to learn when we use these drugs is the fact that treatment associated adverse events causing mortality is seen in about 8.5% of these patients. And our main emphasis on toxicity management is going to be to make sure that our preventive and prophylactic treatment is good so that these patients actually get the best benefit from these new drugs. If you look at the severity of adverse events, grade 5 adverse events were seen in 8.9% of the patients, which is a little less than 10%. And that is something we will discuss again during the session. So it appears that BCMA expression is a hallmark of myeloma cells, and we need to target it if we need to do things that are better than what we have been able to do with the traditional chemotherapy. So we'll discuss cellular therapies, that is the CAR-T, and we'll discuss bispecific antibodies. In today's discussion, we will have a discussion on BiTEs, which are majority of patients have been treated with BCMA CD3 BiTEs. The reason why we thought we will have this seminar is because bispecific antibodies targeting BCMA have transformed the care for heavily pretreated and penta-refractory, relapsed refractory multiple myeloma. And that is what the real world analysis also showed us, that we have to move from the old treatments that we were giving to these newer therapies if we have to improve outcomes of patients who have relapsed with multiple myeloma. We have problems of access across the country. Reimbursement is limited, and it has influenced the number of patients who can get this kind of treatment. But now there is a lot of experience among the Indian investigators. There are lots of global trials in many of the institutes where we are recruiting patients, and our own principal investigators have a lot of experience. There are many questions which will emerge, which include optimal duration, dosing, how we space the dosing, especially in patients who have toxicities, the immune recovery, and the T cell exhaustion eventually. What is important for today's discussion is the new toxicities that we have seen with these cellular therapies, and all of you are familiar with CRS and the ICANS. Most of the BiTEs have early grade 1 and 2 manageable toxicities. The CARs have toxicities which are actually beyond grade 1 and grade 2 and need a lot of prevention and prophylaxis. And so there is need for standardized protocols for CRS and ICANS so that the entire teams in your institutes are ready when patients are being given these drugs. Infection has been a major challenge, and we will show you some of our own experience. It is bacterial, viral, fungal, and sometimes CMV infections also. We have India specific issues, and if you just treat 10 patients, you will see all of this hepatitis B reactivation, tuberculosis reactivating, and of course, we lose patients to multi drug resistant organisms. Hypogammaglobulinemia is universal. Initially, we would give IVIG due to its cost only when the IgG levels were less than 400, but we will have a discussion on what we should be doing as we put more and more patients into this treatment. Vaccinations and prevention is something that we forget very often, but here we cannot afford to forget, and patients must be well vaccinated. We can have a discussion on COVID vaccination also today. Most of us haven't been using it, but we will see what is the opinion of the uh, treating physicians. Then we have other requirements. If we have a lot of these patients at some time, we will require protocols and workflows because a lot of your team will be in the emergency care, and you will need to actually educate the relatives and the caregivers of the patient as to when, how, and where they should come in case the patient has any problem. And so there is a lot of training and education that needs to be done when we are using these drugs. Remember, many of them can be given subcutaneously. So they're very easy to give. But once you have given them, you must know exactly how to take care of these patients. And of course, it's a good time for everybody to come together and have a regional myeloma registry to capture the real world patterns as we change treatment from old chemotherapy uh, regimens to the newer therapies and understand and adapt to the infection management and dosing strategies, which will be for India. So, in a recent discussion in the Asian Myeloma Network, there was a lot of thoughts on how we should be prepared in our area to deal with patients who will require these treatments and who will come with complications. And the three main pillars are essential in having a good hospital infrastructure, procedures and protocols in place, and educating not only the manpower in your institutions, but also providing the patients and caregivers with a lot of education in terms of ongoing AEs, how to monitor them, and when they should report. And then, of course, there are some recommended guidelines, which is important considering that many of these drugs are very rapidly coming not only in the third or fourth line, which we have all used, but in the first line of patients who are relapsing, and maybe even in induction in the newly diagnosed patients. So if you're going to treat newly diagnosed patients with these drugs, we have to be 100 times more careful because myeloma is in a chronic disease, can be controlled over a long period of time, and we just cannot afford induction mortality in myeloma. So with that, I think I thank you all for your patient hearing, and I will ask Dr. Srinath, who has been a very close colleague of mine in Tata Medical Center, Kolkata, and he will do the first presentation on bites. Srinath, all yours.
Thank you so much, ma'am, for such a wonderful uh, initiation of the session. And my slides. Okay. Yeah. So am I audible and are my slides visible?
Yes, Srinath.
Yes.
Yeah. Okay. Thank you so much, Marina madam, for giving me this opportunity, and thank you organizers for providing me the platform. And before I begin, I like to say that I'm being in community hematology practice. My experience with anti-BCMA bispecific is limited. I have just treated only 5 patients with teclistamab, and I don't have any hands-on experience with elranatamab and levosimendan. And so we all know that BCMA is an ideal myeloma target, and mainly because it has only restricted to primary to plasma cells and the large B cells. And generally, BCMA antibodies are universally present on all myeloma cells. And So, and despite of the high risk, low risk, and intermediate risk, BCMA antibodies are seen on all the cells. So, and also that soluble BCMA, that is a potent biomarkers for targeting the drug level, targeting the usefulness of the anti-BCMA medications. So for anti-BCMA, that has a dual action. It has a dual binding. It simultaneously binds to CD3 on T cells and the BCMA on malignant myeloma cells, and hence it bypasses the MHC restrictions. Also, which because of this bispecific nature of these antibodies, it induces T cell activation, degranulation, and secretion of perforins and enzymes, which are cytokines, leading to tumor apoptosis. Also, it has a capability of in vivo expansion, and hence it promotes the localized proliferation of effector T cells within the bone marrow microenvironment. So, what is the clinical advantage over the CAR T? Basically, for CAR T, we have to wait for a manufacturing of these T cells, while the bispecific antibodies are off the shelf and they are easily available. And there is a we have know what is a dosing schedules post RCTs, and generally it has a lower toxicity and a lower CRS compared to CAR T cell therapy. And it is easy to administer in a community practice rather than it did not have a proper infrastructure with we and in fact giving the anti-BCMA antibody, one should not have a proper BMT setup also. Without a BMT setup too, these antibodies can be administered. And there is a lots of discussion whether these antibodies can be given on the OPD basis. Yes, in the future, when we develop more and more experience about usage of this anti-BCMA antibody, we may use this treatment on a OPD basis or on a daycare basis too. So generally, there are three FDA anti-BCMA antibodies are approved, and teclistamab being available for us, and elranatamab will be soon available for us, and linvoseltamab will be is also one of the available bispecific antibody. So difference is in their construct, and generally teclistamab is humanized IgG4, which has a DOBD platform, while elranatamab is also humanized, and it is a Ig2A antibody, and linvoseltamab is a fully human IgG4 antibody. The teclistamab and elranatamab can be given subcutaneously, while linvoseltamab it has to be given intravenously. All three will have a two-step-up dosage, and for teclistamab, the step-up dose is 0.06 mg per kg, followed by 0.3 mg per kg, while elranatamab has a 12 and 32 mg of a step-up dose. Maintenance is 1.5 mg per kg per weekly, and once the patient achieves the CR, uh, which can given to every 15 days. While elranatamab has a fixed dose, which is a 76 mg per weekly, and after 24 weeks, it can be gone on a 12 every 15 days if the patient achieves the partial response. And after 49 weeks, if the patient remains in that response, it can be given monthly. While Linvo, the dosage is 200 mg weekly, which is also standard dose for all the patient, which needs to be given every 2 weekly. And after 14 weeks, if the patient is in remission or other response, then it can be converted to a 4 weekly dosage. 200 mg weekly, followed by 2 weekly after 14 weeks, and 4 weekly after 24 weeks if the patient is in a sustained remission. Every like these are very good antibodies, very fantastic drugs, but these all molecules come with their own baggage of CRS, ICANS, and infections. While the teclistamab will have a highest CRS rate, which is around 72% incidence, and mostly they have a grade 1 or grade 2. And elranatamab also have a grade 1 to grade 2, but CRS incidence is less, approximately 58%. And Linvo will have a least CRS incidence, which is approximately 46 hours, 46%. So Majestic 1 trial, which was one of the important trial, and for teclistamab, and with this they have said a median progression-free survival is 11.4 months. Median overall survival is 22.2 months. CR rates is 45.5%, and MRD negative was seen in approximately 81% of the patient who had achieved CR. So for a triple class exposed patient achieving the MRD negativity with this drug, it's possibility. Similarly, elranatamab, magnetism MM3 was the study for it. And in this, they have showed with elranatamab there is a 61% overall response rate in the patient with triple class refractory patients. And generally, median time to response with this was around 1.2 months. Progression-free survival at 15 months was around 50.9%. And as we have discussed earlier, it can be transitioned to bi-weekly dosage. And because of that, the result significantly reduced grade 3, 4 infection rates and without losing the efficacy. Even with the elranatamab, MRD negativity was approximately 90.3%. Median overall survival is slightly better compared to teclistamab, which is 24.6 months. And median progression-free survival was also slightly better, was around 17.2 months. And CR and CR rates was seen in approximately 37.4% of the patient. Linvo, 71% overall response rate at the 200 mg dose level. It has a progression-free survival advantage. 1-year PFS rate was around 90% in initial cohorts, and its efficacy remains same despite of being the high risk cytogenetics and having the extramedullary disease. And the advantage of linvoseltamab is it has a convenience of administration. It can be given monthly maintenance dose, but it has to be given intravenous. So in this, CR rates are seen in 52.1%, MRD negative in 91%, progression-free survival is 21.3, and overall survival is 31.4 months. So coming to the toxicity profile, like we had discussed, it's a dual-edged sword. And while the efficacy is high, the management of this cytokine release syndromes and infections events should be at utmost priority. And basically, there are three possibilities which are the highly seen with the bispecific antibodies are CRS, but CRS is early, it is predictable and easily manageable. And as we know, the CRS can affect any organ, so we have to be vigilant. Infections can be late onsets, and that could be as we progress throughout the bispecific antibodies, and it can be cumulative too, and infections can be fatal. Cytopenias are transient, but definitely requiring a support. And yeah, so cytokine release syndrome generally uh, median onset is 2 days after teclistamab, 2 days after elranatamab, and fever is the most commonest, and fever will be always seen when we are using this bispecific antibody. And management is very well known. Grade 1 is supportive care. Grade 2, we can use tocilizumab. Dosage is 8 mg per kg plus or minus dexamethasone. And in my experience, where I've used teclistamab, majority of the patient, in fact, all of the patient had grade 1 or grade 2 CRS, which we could manage on our routine practice. So ICANS, in my practice, I haven't seen ICANS post bispecific antibodies, but the incidence is 3% to 10%, and mostly it's a grade 1 to 2. Early detection is a key, and a regular ICE score, that is important. Generally, whenever I am using bispecific antibody, I ask my patients relative to keep talking with the patient, keep discussing, and keep talking about past things. So whether they are able to remember, that's what I just try to interpret whether the patient is developing ICANS or no. Again, the interventions is the same. Dexamethasone and tocilizumab are the treatment. And there are delayed neurotoxicity has been reported. It's rare, but Parkinson-like features with the BCMA targets, that is commonly seen. And so hence we also keep checking the gates and the tremors for these patients. And again, a differential if the patient is in a neutropenia, always to rule out a septic or metabolic encephalopathy before labeling them as ICANS. So my prophylaxis for the patient, of course, I vaccinate all the patients prior using bispecific antibodies. For viral, I use acyclovir 400 mg twice a day, which I continue for longer period, maybe indefinite throughout the treatment, and if I was planning to stop the treatment, at least for 6 to 8 months post-treatment, despite vaccination. For PJP, commonly use Bactrim DS. And for antibacterial, generally for step-up dose for 2 weeks, I use levofloxacin 500 mg daily. And for hypoglyceminemia, IVIG is the key. And I generally target my IgG levels between 400 and 500. I do not blanketly use IVIG for these patients. Above 600 and 700, I generally do not use IVIG. But with this usage of this bispecific antibody, I have seen the patients landing up IgG levels below 202. And so we just keep giving them IVIG to maintain between 500 to 500. So I'll share my experience. I'll be discussing my 4 to 5 cases which I used the teclistamab. The first one was is a 50-year-old man. He was a young man with presented with a renal failure with the creatinine of 9. He had predominantly kappa light chain disease with the bone marrow had 46% plasma cells. Fish, to my surprise, did not show any uh, adverse fish analysis. PET scan had an extensive metabolically active lytic lesion. Initially, the treatment was given DARA plus VCD for 12 weeks. With that, his creatinine had come down. His kappa had gone down to 32 from 6,000. And the PET was in complete metabolic response. We continued on a DARA with VCD, but that time patient was not willing for a transplant, so the transplant was kept on hold. And in October, after 4 months, uh, patient's kappa chain rose to 120, lambda was around 32, and his ratio has slightly gone up. Bone marrow was done again in view of a rising kappa chains, but there was no excessive plasma cells. And most importantly, flow MRD was negative. But the PET scan showed again reappearance of the lytic lesions. So hence the discussion of the teclistamab was done. Patient was initiated on teclistamab. He was given the step-up dosing. IgG levels were targeted above 500. And the patient that time, it was my first patient, so I did not use a tocilizumab as a prophylaxis. But the patient developed grade 2 CRS when he developed hypotension, which we could manage with the IV fluids. And after that, a tocilizumab 400 mg was used. And after 4 weeks of the treatment, he was in MRD negative state, and there was no M-band. PET scan was in CMR, and kappa chains were 36, lambda was 32, and ratio was 123. Based on that, in January 2026, the patient had undergone a transplant and autologous transplant, and we have used a reduced melphalan dose 160. We had given the antiviral prophylaxis, and so far this patient did not have any major events during the transplant or post-transplant things. We continued with IVIG prophylaxis for this patient, and the last follow-up was in June 2026, where we are continuing him on a pomalidomide maintenance. With this, his disease is remaining well within acceptable limits, and so far it is under control. So coming to my second case, it was a 58-year-old female. She was a lambda light chain myeloma, diagnosed in 2020, and her fish was a 1q deletion. Initially, that time she was treated with a VRD into 4 cycles, transplanted in June 2021, and followed by lenalidomide maintenance, which she continued for 4 years. In February this year, she come with the relapse where lambda chain rose to 1800, creat was normal, and hemoglobin was 10, WBC was 2900, and platelets were 205. So her bone marrow showed 30% plasma cells, hence that she was not DARA exposed in the past. She was started on a DARA bortezomib pom dexa as a quadruplet therapy, which she received for 1 month with a weekly DARA, weekly bortezomib, and pom and dexa. But she did not respond well. In fact, she progressed. Her hemoglobin dropped to 6.8, WBC was 1300, ANC was 800, and the platelets were 23,000. And her lambda also rose to 3,400. And in fact, her creat also gone up to 3%. So this time there was a dilemma whether patient is having a pancytopenia, patient is having a thrombocytopenia, whether to take this patient for teclistamab because label says in the patient generally with the platelet less than 50,000, we should not use this drug. In fact, this patient, we had referred for her to a TMH also, where they are doing the teclistamab trial. Also, that patient was not eligible because of the low platelet counts. But after thorough discussion with the patient and her relatives, we decided to go ahead with the teclistamab. Again, for teclistamab, step-up dose was using. This patient was little weight was low, so though it is not allowed, we did a splitting of the vials. And for this patient, we also use the tocilizumab prophylaxis. And again, IVIG prophylaxis as a routine, we continued. So 4 weeks of the treatment, there is no M-band. The kappa light chain, lambda light chains, and gone down normally. Hemoglobin is 11.4, WBC rose to normal 6,800, and platelets are 1,40,000. So she also responded pretty well, and the creat also had come down. In fact, to my surprise, her bone marrow was showing a 0% plasma cells with the MRD negative status. Again, this lady went for a second transplant. We used Melphalan 200, though there was a we had to do 2 apheresis for her to get an adequate stem cell dose. And during her transplant, we had a problem. So we had she had a significant C. diff infection. Also, she had a CMV reactivation for which we had to use ganciclovir for this patient. But patient was discharged, and so far her hemoglobin, WBC platelet, and creat remains within normal limit. She today only sent me her IgG reports. IgG reports are between around 700. So this was we had 3 patients who had undergone autologous transplant post teclistamab. This was the third case, high-risk multiple myeloma, DARA VRD induction failure after 2 months, persistence of the disease 35%. She also received a teclistamab, achieved a MRD negative and ACC. And as we are losing more and more DARA upfront, we are using lots of DARA resistance in newly diagnosed patient. Uh, we are seeing approximately 5 to 6% of the patient having a DARA resistance, and the same with the relapse refractory. DARA resistance is being seen into 20 to 25% of the patient. So what was my rationale for a transplant? So generally, as we have seen, bispecific can drive the highly refractory disease into MRD negative state, but durability is often limited, especially with the T cell exhaustion. And so far, there is no discussion how long to continue this bispecifics. And as we are practicing in a community, we have to always think about the cost. And always there is a cost barrier for treatment for all the patients. So again, immediately following the immune-related cytoreduction using the high-dose chemotherapy, we can consolidate that MRD negative state using the non-immune dependent mechanisms. So these are my thought process before I taken the patient for a autologous transplants. Yeah, we had 2 deaths also while we use the teclistamab. Important is one of the patient, and mostly both these deaths, what I could figure out is not because of the infection, and they are mostly because of the disease progression, and uh, uh, that's what we have seen. So one of the case I would like to discuss, she was a 63-year-old female. We had given the VRD induction. Post, she was a high-risk patient. She relapsed immediately after 16 months of transplant. Again, she had given the DARA KRD as a reinduction. Again, she had a progression. She also received the teclistamab, and on teclistamab also she had a progression. Her light chains kept on rising, and her hemoglobin kept on going down. We had tried using DARA plus teclistamab as a majestic 2 data. Despite that, the patient had a progression, eventually succumbed to the progressive disease. So total my experience is 5 patients on teclistamab. All the patients were triple class exposed, and response rates were around a 3 out of 5, achieved a complete MRD negativity. All the patients received IVIG prophylaxis. I had used tocilizumab prophylaxis in 3 out of 5 patients, and grade 1 or 2 CRS was seen in those 2 patients, which I did not use tocilizumab, while other 3 patients did not have any eventful CRS. Grade 3 or 4 CRS is 0. infection I've seen in one patient with a CMV and a C. diff. ICANS, none of the patient had ICANS, and that I could see in two patients, and that was because of the progression. So why to introduce the any bispecific antibodies early? Because in as we have seen, the patient is still immunologically competent. We should not wait to patient progress on to patient become the penta refractory, then you use it. At early relapses, it has a lower disease burden. Patient has a better T cell fitness, and generally we keep on using multiple new drugs that can lead to late line marrow exhaustions. And with the usage of this bispecific, we can have a opportunity to achieve for a deeper response. And hence, with that, we can achieve the clinical objectives of achieving a deeper response, maintaining good performance kinetics or performance status of the patient. And early usage can have a lesser infection complications. We can keep the dose intensity if you use early, and also extend the duration of the response. So my top implementation lessons while using the bispecific antibodies is like the vaccinate all the patients, early tocilizumab. We can use, we should not wait for grade 3 CRS. Treat early to keep the patient on the therapy. IVIG, yes, we have to keep maintaining the IVIG for hypoglobinurias. Subcutaneous is better. And I always involve a neurologist and my ID physician before I'm initiating any patients on bispecifics. Uh, Even that fact, I have to discuss in detail about the ICANS with my neurologist before I could start this molecule in my hospital. And for teclistamab, we can switch to bi-weekly or dosage when the patient is achieving the CR. And transplant is a viable option. So far, I did not have any major events for getting the adequate stem cell dose post bispecifics. Though my experience is pretty new, and I'll have to wait for a longer follow-ups for coming to the conclusion. With this, I end my talk. Thank you so much for patient listening, and I hand over session to back to Rina ma'am. Thank you.
Thank you, Srinath. It's nice to listen to actual experience. And now we will have the next presentation from Dr. Hari, who will actually discuss.
Yes, thank you, ma'am. I just try to, if we can, I can share my slides. Yeah.
So the other person has to stop sharing. I'm so sorry, my screen has hanged. I'm just trying my best. Sorry, I'll just try to switch it off and I'll rejoin again. Sorry for that.
No, not a problem.
That's it.
Can you see the screen?
Yeah. I could do that. Sorry.
Yeah.
Yes, Hari, go ahead. We can see and we can hear.
Yeah. So I just wanted to. I've got this new screen. I'm just trying to. Okay.
Is it still visible?
Yeah, it's visible. My slides are visible.
Yes.
Yeah. Okay.
No,
Yeah.
sir. Not visible yet.
Okay.
Hari, screen is visible, not your slides.
Your slides, yeah.
Okay. Share. Is it visible now?
Yes.
Yes, sir. Visible.
Okay. Thank you. Thank you. And after two wonderful lectures with Reena ma'am, actually putting the concept of treatment of relapsed refractory disease in process, and also the talk on bispecific antibodies. We switch over to another session, and I will focus mainly on our Indian experience. We do have the data on the two main uh, CAR T cell products, which is the silpiceptin and the idacaptogene products, which is basically from the Karma study, and also the the Cartitude study. So I'll try to get into the concept of CAR T cell therapy a bit, and I'll just start. It's always good to know what the biology of the myeloma is disease, because it's basically a disease from a pre-malignant proliferation of monoclonal plasma cells it's a multi-step acquisition of genetic and microenvironmental changes, which allows for the transformation of the cells. And also, myeloma mostly evolved from MGUS, we all know, and may go through a smoldering myeloma or may directly get transformed into a myeloma. And in this process, there are several genetic abnormalities that are acquired, and they emerge in the tumor plasma cells, which contribute to the pathogenesis of myeloma. So, what we try to understand or try to do when we are confronted with a diagnosis of myeloma is to see how best we can control the disease. And that we do through several processes, which includes either systemic therapy with anti-myeloma agents to start with or without incorporating a stem cell transplant as a consolidation process. Because at the end of the day, we are trying to get the best possible responses, increase the depth of responses, and once we achieve those depth of responses, try to sustain those depth of responses. And we are largely successful in doing that in most of the cases, but a lot depends upon the cytogenetics and also the molecular makeup of the disease. And also, I will allude to more recently the new concept of functional high-risk myeloma, which at face value will appear to be like a disease that is standard risk-like, but will behave like a high-risk disease, although we don't have the molecular profile that will categorize it as a high-risk myeloma. So what happens is that what do we do once we have a disease which is invariably going to progress at some point of time? And that's when we are having a challenge, because at this point of time, when you're treating the disease, there is a progressive shortening of the responses and increasing development of resistance to the disease, which results in most of the conventional drugs that we use for treating myeloma at the time of diagnosis does not really translate into any long-term outcomes in these patients. And that is what Dr. Reena, ma'am, alluded to do, which is the triple class refractory myeloma disease. This is an extremely difficult disease to treat, and the outcomes are uniformly poor. And with the incorporation of the standard risk versus high risk disease, the high risk disease doing worse, the depth of responses that is achieved, and the duration responses translating into better or worse treatment-free survival. So the disease becomes aggressive in triple refractory disease. The median survival, whatever we do, is probably around 4. Progression-free survival is about 4 months. The median overall survival is about a year. And of course, the high-risk cytogenetics, as I said, worsens the prognosis in these patients, worsens the outcomes in these patients. And we are always in the quest for achieving any sort of response to improve survival over here. We do have to resort to some other forms of treatment over here, and that's when the concept of immunotherapy came into being. And so, why immunotherapy might be a useful way to look at it is that myeloma cells are immunogenic. They express tumor-specific and tumor-associated antigens, including BCMA, SLAM57, CD38, and this immunotherapy will leverage these antigens to selectively target and eliminate. And this is a concept which has actually partially translated into achieving the objective of controlling and also eliminating myeloma cells. The second thing is that myeloma causes significant immune dysregulation. So trying to reset that that immune dysregulation may be something that we try to attempt. And the suppression of the normal T cell function is usually encountered most of the time in myeloma. There is expansion of the Tregs, which suppress the immune system. And also there is exhaustion and the dysfunction of the cytotoxic T cells and natural killer cells. The third concept is that there is a tremendous ability of the myeloma cell to have immune evasion. So there is a downregulation of the antigen presenting, especially there is a low MHC class 1 expression over here. There is a creation of an immunosuppressive microenvironment through cytokines such as IL-10 and transforming growth factor beta. And also, there is also an overexpression of many of the inhibitory checkpoint molecules, especially PD-L1. But targeting the PD-L1 has largely been largely a failure in myeloma for reasons not fully explained. Fourthly, the bone marrow microenvironment, I said, is a critical site where myeloma cells interact with the stromal cells for its survival. It interacts and the cytokines that are over there promote the cell tumor growth and immune suppression. So targeting the unique myeloma antigens becomes a very useful kind of a strategy to try and control the disease, and not through any anti-myeloma therapy, but directly through exploiting the cellular therapy over there to do the job that is sort of suppressed in the myeloma microenvironment. So the BCMA targeted CAR T cell therapy and the bispecific antibodies fall into this category. And so we also try to harness the immune system memory T cells, because we do understand that the type of cells that really allow for immune-mediated response are the effector T cells, or the effector memory T cells, actually. And so we try to train the immune system to remember myeloma cells, potentially leading to a durable response over there. Thirdly, you try to exploit the synergistic effect with other treatments. So combining immunotherapy with other treatments like with proteasome inhibitor may be another strategy. So we do understand the story of daratumumab, which is an anti-CD38 antibody, and like rituximab, it allows, and daratumumab and cetuximab, it exploits a complement-mediated dependent cell cytotoxicity, antibody-dependent cell phagocytosis, antibody-dependent cellular cytotoxicity, direct apoptosis, and modulation of the ectocellular enzyme activity to target the tumor cells through the CD38 antibody and induce a cell kill. But so if CD38 is a target for CAR T cells, why not use it as a target for CAR T cell therapy too? But you can't do that. It's not that simple, because CD38 is ubiquitously expressed on your normal cells, and they are sort of, if you were to target the CD38 through a CAR T cells, it would be akin to having something like a pan hematological ablation. Similarly, they are exquisitely expressed on CAR T on the T cells themselves, because the T cells upregulate CD38. And if you were to use a CAR T cell which is targeting CD38, it will lead to fratricide. And there is also the high risk of destroying the hemopoietic cells, because we should understand that CD38 is expressed profoundly on the hemopoietic progenitors. So for all these reasons, we really cannot use the CD38 as a target for CAR T cells. So it has been looked at what can be an appropriate target. And because an ideal target would be BCMA, or the B cell membrane antigen over here. And that is, and let us explore why it would be appropriate. One, has restricted expression with minimum off tumor activity, and it has a uniform high expression on myeloma, there is a biologically essential for they are biologically essential for myeloma plasma cell survival, and there is a less of an antigen escape because of the presence of BCMA, and also they are importantly absent on stem cells. So there's a stem cell sparing effect if you were to target the BCMA over here. And then there is a very high antigen density that prevails there, which allows for a strong CAR T cell activation. And also there is a terminal lineage targeting, which allows for manageable toxicities over here. So the BCMA is basically a type 3 transmembrane glycoprotein associated with the tumor necrosis family receptor superfamily, and their function is basically to regulate B cell proliferation. It binds to ligands, proliferation inducing, especially APRIL and BAFF, or the B cell activating factor. And APRIL and BAFF actually via the BCMA are essential for humoral immunity. And blocking this interaction prevents antibody formation over there. And so that's what has been exploited to target the BCMA through various ways of doing it, one of which is using the CAR T cells. And in the previous talk, what was described as using the bispecific antibodies to target the BCMA. And also there have been attempted at the use of naked antibodies also. And there have been other antibodies also, other receptors also that have been identified, especially the GPRC5D, which is targeted by another bispecific, which is talquetamab, and also FCHR5, which is targeted by cevostamab. We are exploring SLAM F7 as a marker for CAR T cells, but it is still in the process of evolution. So they targeted the BCMA with the immunoconjugate, which is technically targeting a chemotherapeutic drug using BCMA as a target, is another strategy that has been adopted. But we will stick now currently to the topic of CAR T cells in myeloma over here. So as we know, there are the first generation CAR T cells, which have solely a CD3 deriving signaling domain over there, and there is a co-stimulatory domain is also present in second generation CAR T cells. So that's what makes it a second generation CAR T cells. And now in evolution, there is a third generation CAR T cells where there is a co-stimulatory, two co-stimulatory domains, which I'm happy to say is being designed in India also, and is very close to being marketed with the third generation CAR T cells, which has two co-stimulatory domain. And the co-stimulatory domain are quite important as far as the activity of CAR T cells is concerned. So you have a CD28 over there, which will allow for a profound T cell expansion whereas if you use a co-stimulatory domain in the form of 4-1BB, which is very commonly used in both in the CARTITUDE study, which is siltecaptazine, allows for better persistence of the CAR T cells over there. So it only goes on to say that what if we were to combine both of them? But the challenges do exist when we combine the two, but that's what is explored in the third generation CAR T cells. Then you have the fourth generation CAR T cells, which is also in evolution, being in the laboratory. The trials are ongoing, which express chemokines such as IL-2, which are activated on the binding of the CAR T cells. And then you have the fifth generation having a unique co-stimulatory domain that activates specific signaling pathways, especially the JAK-STAT pathway. But we are now confined, and the data is mostly for the second generation CAR T cells right now. And the Indian CAR T cell also was a second generation CAR T cell. So as far as the CAR T cell study, it all began with 3 phase 1 trials between 2015 and early 2016, which were published. The UPenn came up with the CAR T cells, which was the first in the first in human BCMA targeted CAR T cell construct, which established BCMA as a viable antigen. But this was a primarily an early phase non-commercial study, and it was not taken into practice. The second study was the Bluebird Biotech study, which was multicentric in the United States, which was published in the New England Journal with Dr. Nupur Raje being the lead investigator over there. This is developed by Bluebird Biotech in collaboration with Bristol Myers Squibb, and this is what later on translated into the Karma study, which was a pivotal phase 2 study for idacaptogene, which is a BMS product, and which was initially evolved by the Bluebird Biotech. And in this phase 1 study, you did have an overall response rate of greater than 70%. Then came the Legend Biotech, which is from China, which was later developed into cilta-cel, which we all are aware of as the CARTITUDE-1 study, and CARTITUDE-1 and the CARTITUDE-4 study, which was developed by Legend Biotech. And you had the CARTITUDE-1 trial. You have, in this particular thing, that you have a dual BCMA epitope, and also with a very high avidity. And the Indian product, which was manufactured by Origin, which is supported by Dr. Reddy's laboratory, was very much akin to this to cilta-cel product, which is very much similar to this product, this molecule, except for that the lentivirus was a little different. So what we see is an academic discovery coming from the UPenn initial observations to a scalable therapy with enhanced biological activity. So the Karma, the products that we have is a Karma 1 and the Karma 3 study, the idacaptogene, which is for Karma, and cilta-cel, which is with the CARTITUDE-1 and the CARTITUDE-4 study, which was a phase 1, 2, and the phase 3 study that was there. So you had very, very profound responses. All were used in pentarefractory diseases, except for, of course, the phase 3 study, which allowed for failure of 3 lines of therapy to be also included. So the overall responses were profound, and we are talking about responses to the tune of anywhere between 73%, with the CARTITUDE-1 study even showing responses to the tune of 98% and 85%, far better than, probably far better than, I would not say far better, but better than the Karma study, which is observed. But there are reasons for that also. So, the Karma update is that you had a progression-free survival which was profound. Yeah, you had a 13.3-month progression-free survival with 77% overall response rate and a 39% complete response rate with improved outcomes over here. So, and also and this was against the standard regimen, which was the Karma 3 update. So, with an overall response of 71%, complete response rate 39%, and also MRD negativity and deeper responses being substantially higher for the idacaptogene arm. And the CARTITUDE study also mirrored the same kind of an outcome with the progression-free survival at a median follow-up of 33 months. The risk of disease progression or death was markedly lower. The 30-month progression-free survival was close to 60%, and the median progression-free survival was not reached. And the overall survival, the reduced risk of death was by about 45%, with the 30 months, the overall survival being 75%. And mind you, this is for patients who were either triple-class refractory or pentarefractory disease. So more importantly, something that we never came across in this class of patients is the achievement of MRD negative status, which is unheard of in this class of disease. So you achieved MRD negative status over here, which was probably far higher with cell-to-cell in the intent to treat analysis. And more importantly, also for those patients who achieved an MRD negativity and sustained MRD negativity, it was technically going towards a functional cure. So we have the more recent data of almost a 32% follow-up data of 32% myeloma-free survival at the end of 5 years for the cilta-cel arm, or what we call as the CARTITUDE-4 study. So I'll come back to our Indian data, which are just presenting the phase 1 and 2 open label multi-center study to evaluate the efficacy of DRL 1801 in patients with relapsed refractory disease. The study allowed for patients who had failed 2 lines of therapy, and it was not mandated that they had received daratumumab also. So even patients who had not received daratumumab but were refractory to 2 lines of therapy were included in the study. So this was akin to, and it is called Libracel, and this was akin to, very similar to the cilta-cel construct over there. And the nano, and this was basically a nanobody. The nanobody is derived from variable domains of the heavy chain only antibody, and they are produced by the shark, from the Camelidae family or the sharks. And we all know that the sharks have very profound immunity, and they are practically resistant to any sort of infection. So it was basically derived from that concept over there. And the sequence of the nanobody, that the variable heavy chain and the human heavy chain is similar over here. So the nanobodies can be humanized, and that's what was done over here. And it also had something like an extended CDR3 finger, which allowed for a better binding into the grooves of the antigen, which in this case were the BCMA. So Ribracel as an nanobody was similar to cilta-cel or Carvykti, and it was different from ide-cel or Abecma that was over there. So the Ribracel manufacturing process was an optimized process. Initially, it was done through bags, and now later on in the subsequent, they used as a Gatherex pump, which allowed for better manufacturing process and better purity of the CAR T cells over there. And so when we looked at the preclinical efficacy data, there was in vivo efficacy was clearly demonstrated in mice. The survival.
You
Hello, yes, ma'am.
Can you go a little faster? We are going a little late.
Okay. So the preclinical efficacy of Ribracel was also demonstrated over there. And so in the patient demographics, whether we used 5 million cells or 10 million cells, where really did not matter over here, with profound responses coming in. The overall efficacy in the phase 1 data, we had 10 patients, 6 out of the 7 patients with CR achieved also a stringent CR, which were MRD negative. And when you looked at the pharmacokinetics of this, there was the good expansion of the T cells on day 28, and also the persistence, which actually lasted for about six weeks, with disappearance of the cell subsequently. But what was important was the sustained response that was achieved. And when you compare it with the idacaptogene data and the ciltacabtagene data, it was pretty much comparable over here. So moving into the phase 2 study, we encountered several problems in the sense there were 60 patients encountered, but the data that was seen in the phase 1 study did not get completely replicated in the phase 2 study, although the manufacturing process, etc., was similar. But the manufacturing process, the only thing was in the phase 1 study, it was using Takara bags over here, but we use the G-Rex technology over here, which is a superior technology for manufacturing T cells. But there was 100% manufacturing success in the study over here. So, but the CR rates were, when it was about 77% in the phase 1 study, it dropped down to about 46% in the phase 2 study over here. And also it had a pretty well balanced arm with low risk being there, but marginally higher low-risk patients in the phase 2 study, which again did not explain why they did not have a better response rates. But what was it? There was lesser of hematotoxicity score, less comorbidities in the phase 2, less baseline hypogammaglobulinemia, similar median previous lines of therapy, and of course we encountered 3 fatalities, which we never encountered in the phase 1 study. But that is only naturally to occur. That's only natural to occur in these patients, and it was important for us to analyze what is there. But the median progression-free survival was about 21 months in the phase 1 study, whereas it was only around 10.1 months in the phase 2 study over here. So I'll just, in the interest of time, I'll just go ahead. I will not. There was not much of CRS activity over here, and some of the grade 3 was more encountered in the phase 2 study, but everything was managed adequately. The phase 2, even when you look at the pharmacokinetic study, the phase 1 and the phase 2 mirrored one another in terms of the T cell expansion, because in the phase 2 study, we had used only 5 million cells, which was determined in the phase 1 data. So this was the swimmer plot, which looked at the survival of the patient, and there were about 48% long-term survival at the last follow-up for these patients of the total of 24 patients, which includes both the phase 1 data also. When you look at the current status, Ribracel, the Indian, we have completed the phase 1 and the phase 2 study, and patients are on follow-up with about 48% long-term outcomes of these patients. So the takeaways of myeloma CAR T cells is that BCMA CAR T cells delivers unprecedented depth of responses. The KARMA study showed significant improvement. The KARMA and the CARTITUDE study is significant improvement in progression-free survival and overall survival. The safety profile were increasingly well characterized, and the CRS was not as CRS and neurotoxicity were predictable and were well managed with standardized management, and the access and manufacturing logistics where actually the time to vein time was about 18 days over here, which was in our study was almost 18 days. So it is working on a clinical platform. The preliminary data has some concerns, especially with delayed hematotoxicity being one, and the early deaths couldn't be attributed to the therapy per se, which was when we did a root cause analysis over there. The longer follow-up is, of course, required, and the longer follow-up hopefully will demonstrate the durability of responses, because we do have in the set of 24 a significant proportion of patients who are still continuing to either be disease-free or with some sort of biochemical relapse in these patients. And with that, I will conclude. Thank you.
Thank you, Hari. That was an exhaustive presentation on CAR-T, and so much to learn. So
Thank you.
I'll just make one announcement, and Amish, you can start getting your slides on the screen. We have extended the time by 15 minutes. I haven't seen any question answers in the question answer section, and I would like all the participants to put in those questions so that at the end of the moderation of the panel, Dr. Anupama will help you get answers of what is actually worrying you. May not be CARs and bites, but anything that you feel particularly for your patients of relapsed refractory lymphoma. Amish is also a colleague of mine from Tata Memorial Hospital. He is now a big man in New Delhi, and he is the director of HOPE. And there is much hope in today's presentation for refractory myelomas. Amish, all yours.
Thank you, ma'am. Thank you for inviting me. Is my screen visible?
Yes, visible, and your voice is clear.
Perfect.
Hello, Amish. We haven't met for a long time. Yes.
Hi, Hari. I'm waiting for you to tell me how fat have you become, Amish? Reduce your weight. So it was a very nice and exhaustive presentation, Hari. And I think Srinath also, I liked the presentation. You have 5 cases. We are yet to receive 1 case. So don't worry, we are far behind. In fact, I was telling Dr. Reena Nair ma'am yesterday only that medical oncologists should now go back to hematology as Hari has done, because this very fascinating and exciting era. So, Will, my topic today is optimal management of toxicities of patients receiving bites and CAR. Uh, I 1 minute. My screen is not moving. Next. Okay. So we have three panelists today. I think Dr. Anupama is going to take the questions from the audience. So we have Reena ma'am, Dr. Hari, and Dr. Srinath. My first case is 64-year-old male diagnosed with multiple myeloma IgG kappa in 2022. VRD induction with maintenance are given for 2 years. Patient did not want bone marrow transplant. He was MRD negative after 6 cycles. Patient after 2 years of maintenance are lost to follow-up for 1 year and 3 months. He had a pathological pelvic bone fracture in Jan 2026, and at that time, investigations were done and was found to have recurrence of myeloma. Advice for daratumumab-based therapy. Sun took few opinions in US and suggested that we should give teclistamab plus daratumumab. Hari, the right decision in July 2026, second line teclistamab. And when do you call immunomodulatory refractory? The definition says 60 days after you stop, all immunomodulants. What do you take as, will this patient be in a refractory setting or is in sensitive setting?
No, I would think about still utilizing the standard anti-myeloma therapies over here because he's had a fairly long innings and probably he was off treatment also during the time of follow-up over there. So it's very likely that these are the patients. If you look at the data of the VISTA study, etc., the use of CAP, if he has responded very well to the VRD protocol, I think this would be the ideal candidate for him to go in for carfilzomib-based therapy because he's likely to respond. And when you're using carfilzomib-based therapy, re-challenging with lenalidomide or even using pomalidomide over here would be I would say that the first step that one has to take. It would be a little too preemptive for us to think about using teclistamab. But then the use of daratumumab is again supported by the Pollux and the Pollux study and the other study. I forgot the name. Yeah, the Pollux study and the other study which
If
uses
I
that.
remember, Hari required at least 2 previous lines of treatment.
Yeah, previous lines of therapy. But given that this patient was on maintenance therapy, and also I think we can borrow a page from that to try and introduce daratumumab over here. But perhaps daratumumab would work best in this situation rather than a patient who was on maintenance therapy and progressed while on maintenance therapy.
Perfect.
So the choices over here, I would give the patient first is to use either a daratumumab-based regimen with carfilzomib, or with that, if the patient was not on lenalidomide for some time, use lenalidomide over there and also have a short course of steroids. That's all. Yeah.
Right, perfect. Dr. Srinath, patient, I will not ask you what you will do because Hari has given an extensive. Patient told me that, this is the latest FDA approved regimen, unprecedented results from phase 3 Majestic 3 study. And, if you look at the NEJM article of February 19, 2026, they have said even just 1 line is sufficient for you to enroll on this study. Although the median 2 lines were given, but 1 line also there were 29 to 30%, and you see the 36 months progression-free survival. This is as good as Hari's results of CAR T cell therapy, where patients just do not relapse. If you see there is a plateau, of course, there's a lot of censoring in the end, but you see there is a lot of plateauing of that. So what do you think, Dr. Srinath? Would you agree for this teclistamab daratumumab in second line myeloma? after 4 years of first line?
Now, I was going to allude to this article of NEJM, and right now we have a FDA approval for DARA plus TEC
Correct.
as a treatment in a first line relapse. And so this is fantastic result. And for a discussion sake, of course, I treatment exist, and this is the one I would suggest you to go.
Dr. Srinath, I'm the
So
only one who's not able to hear you well.
No, there is a problem.
sorry for my poor network.
If you can switch off your video, we may be able to
Yeah, I
hear
can
you.
do that. Sure, that's a good idea. Yeah, turn on my voice.
Yeah.
Yeah. So, like I said, I was going to allude to this article, and this is a fantastic data. The curves, if you can see, it's such a straight line, and so like for a relapsed disease for multiple myeloma, these curves unprecedented. So I would definitely give this option to my all the patients who are relapsed after a first line of therapy. If the finances are there, then definitely that choice of treatment I would give to the patient. But another option, I would also think about DARA-based treatment for a
Yes.
first-line relapse if the patient hasn't received DARA
So this is
in
DARA plus Teclin, Srinath. DARA
yeah,
is
DARA
involved
plus
in
take.
this.
Yeah. Yes, of course.
Huh.
Yeah,
Fair,
DARA
good.
plus chemotherapy. Yeah.
Reena ma'am, just one line. Would you give teclistamab DARA or DARA carfilzomib based in this patient?
So if I have to see, the younger guys are more aggressive and I am the oldest. But this data is kind of speaks for itself. We have never seen 80, 90% at 42
Correct.
months. It was always down to near zero at 48 months. So this is something all of us will look at for certain. But I agree with Hari that while we get used to these drugs, our safer options, which do no harm to the patients, still remain a DARA-based therapy for somebody who's relapsed 1.5 years later with the traditional drugs like carfilzomib and pomalidomide in this case. So I am still old-fashioned.
So
So
that
can I
But
just
again, the advantage of
yes,
this,
yes, Hari.
everything.
But quick note. We have 10
yeah
more minutes. Huh?
Yeah, so no, so what I was trying to say is that we have drugs such as teclistamab, which is profoundly active even in the third line and fourth line and the fifth line setting also. While it is something like you would like to reserve these drugs for a later date, knowing the biology of myeloma as being having a relapse remitting course. So from that perspective, maybe I'll use. But the data is super over here, and increasingly, I foresee that in the future, these will all come into the second line setting. The
So
use of
this
cellular therapy.
reminds me, Reena ma'am, my first two daratumumab, both were doctors, and I hired one intensivist to stay there for 5-6 hours, reading the FDA pack insert that dara can cause. And now, subcutaneous daratumumab patient comes and goes, we don't even realize what happens. So I think similar thing will happen with teclistamab. More we understand. Immunotherapy, when it came, I remember now we have seen all types of reactions of immunotherapy. So I'm sure we will be bold enough very soon to use this in the second line. And this was the forest plot that I have hardly yet to see. I remember Solo 1 in ovarian cancer had this type of forest plot chart that everything favors teclistamab plus daratumumab. This was the side effect profile in this phase 3 data: hypogammaglobulinemia, cytokine release syndrome, and diarrhea. I was really happy to see that CRS was 60%, any grade, but grade 3 and 4 was 0%. So that was something very nice. And as ma'am said, talked about the COVID. 43.8% had any COVID positive, and out of 6%, 6% of the patient had grade 3 to grade 4 COVID. So, Dr. Srinath, before starting teclistamab and daratumumab, what will you do? Prophylactic, preventive? So, my question was, what is the role of vaccines? If yes, when and which? IV tocilizumab and IVIG as prophylactic. And Dr. Srinath, very quick answer I would request because
Yeah,
we
sure.
have the entire case to discuss.
So generally, I vaccinate. I generally use three vaccines upfront. That is a pneumococcal vaccine, influenza vaccine, and HSV Shingrix vaccine. And I generally try to use that at least 15 days prior initiating on a bispecific antibody. IV tocilizumab, I'm become wiser, so I'm using for all the patients upfront as a prophylaxis. And IVIG, I keep my targets between 400 to 600 for IgG levels. This is my uh,
Great.
action method of action.
I got it because you presented and slowly you have your evolution was very clear in your cases. Reena ma'am, you were talking about the COVID vaccine, and there were a 7 to 8% of patients who had grade 3 COVID. Ma'am, what would you suggest? When to give? Do we need to do any antibodies before we give COVID vaccine?
So, we had a lot of discussion on COVID vaccines, and somehow the thing is that we have to put our data together and see. But I don't think any of us who have been using, and it's not only a few patients in our paper which we have presented, but we have been a part of many clinical trials in these drugs at Tata Medical Center. And we really haven't seen COVID. So there is a I question every time somebody says COVID vaccinations because we really haven't seen that kind of grade 3, grade 4 bad lungs, which we saw during the COVID epidemic. COVID coming positive is like any viral infection now. So
Absolutely.
we can absolutely discuss, but I'm not sure whether we should be revaccinating. I believe presently the vaccine is not available also in India.
With Hari, with the bites not having any single grade 3, grade 4 CRS or ICANS, uh, 8 mg per kg of tocilizumab, one single dose, money worth well spent, according to you? Quick answer.
So the thing is that it's money well spent when we are talking in terms of a CAR T cell therapy, because the CRS that emerges in a CAR T cell therapy is pretty profound, and the moment it starts coming up, one of the causes for increased morbidity is the CRS. So there is an increasing tendency for having low threshold for using tocilizumab in the CAR T cell therapy background, but many people, my colleagues I have come across, are using prophylactic tocilizumab, which I think is a pretty much of an overkill. But I wouldn't find fault with the fact that even thinking about using tocilizumab, even in grade 1, may not be a bad idea, because we want to abrogate the increase in the CRS that might happen if you don't use it in time. So from that it is pretty much definitely for grade 2, but maybe even for grade 1. But I wouldn't push too much for prophylactic.
Right. In this blood article in a single center, what they showed, which I was worried little bit when I was reading, that will it affect the ORR? And they have shown that it does not change the ORR, reduces the CRS and ICANS. I think that is great. Single dose, I personally think is, yes, money worth well spent. And
That
Dr.
one
Srinath, yeah,
just a small thing is that ICANS is something that develops a little later. Not
right.
CRS always occurs much later, but in presence of if you have ICANS, please don't use tocilizumab, because it might aggravate the situation actually.
Perfect. Point well taken. Immunoglobulin prophylaxis, I think Srinath said that you need to keep IgG level above 500. Some people said above 300. And this particular article says that regardless of IgG levels, you should give IVIG prophylaxis if the patient can afford, just immediately after bispecific therapy. And this was one of our Indian data, real world data on anti-BCMA, where the first author is Dibakar Poddar, and Reena ma'am is also author in this. I think she is the corresponding author. And they have presented their own 9 patients data. What I was seeing that hypogammaglobulinemia was seen in 88% of the patients. 9 patients had 23 episodes of infection. I'm sure, Reena ma'am, at this point of time, you would not have used prophylactic IVIG. Probably then the infection episodes would have been less. Um, there is, so that is what they want to say, that is quite effective, but you need to look at the side effect profile also. I think teclistamab, everybody says that if you use the step up dosing schedule, day 1, 4, and 8, nowadays there are articles of day 1, 3, and 4 also, but day 1, 4, and 7 remains the standard dose, and that is what the dose was given to the patient. Day 8 of the treatment, patient complains of only fatigue, but very exhaustive fatigue. Patient said, "Sir, andar jaan hi nahi bachi hai." And there was no fever, but at that point of time, ferritin LDH electrolytes were okay, clinical exam, no new findings, vitals okay. Dr. Srinath and Dr. Hari, will you take this as CRS beginning or you would wait?
The yeah,
Yes,
it's
go ahead,
after you.
please,
It's after
go
you.
ahead. No,
Okay.
go ahead, please.
Okay, so
Please
this
go
does
ahead.
not clinically fit into CRS because patient does not have fever, and I think for CRS, fever has to be
Mandatory.
there, mandatory. So I wouldn't take this as of CRS, but I'm also not sure whether to label fatigue as a CRS.
So,
Sudden fatigue, sudden onset of fatigue. Patient was okay
so
2 days back. Yes, Hari.
I would think that this is because we give B cell lymphodepletion therapy over here. It might be because of the chemotherapy that we have given, which is something that develops at this point of time, and probably there might be a little drop in the blood counts, and probably the effects of the chemotherapy is probably what we see at this point of time. But we have to take into account the possibility of infection also over here, and that has
So
to be
at
kept
this
in the
point
Yeah,
of
picture.
time,
infection, yes.
Hari, before the development of fever, would you also do sepsis workup and would you rule out TLS, hemolysis syndrome, and pulmonary embolism because these are other causes of fatigue in this setting? Or
No,
you would
not
wait?
no. I would wait. I would wait. Yeah,
Agree.
I would
Reena
wait. Yes.
ma'am, anything new other than what other two panelists have said you would do?
Yeah, severe fatigue in a person, I would worry about infections. And especially if we had done the CBC at this time and we found cytopenias, then I would do
Certainly,
this work for certain.
Right.
certainly,
So
certainly, certainly.
fatigue,
Yes.
rule out infection, stroke, sepsis. I have had one patient on immunotherapy having extreme fatigue and turned out to be pulmonary embolism. I can never forget because for 2 days we kept missing ABG findings suggestive of pulmonary embolism. So ma'am's point very well taken. Day 9 patient had fever 38. श्रीनाथ आपका बुखार आ गया पेशेंट को फाइनली
बुखार आ गया तो CRS, बुखार आ गया, ब्लड प्रेशर लो हो गया, CRS.
fatigue
Under
persists, low BP, no other symptoms. What will you do? So this is the NCCN guidelines. Srinath, you follow NCCN guidelines, you follow
of
something else.
course, NCCN guidelines.
NCCN guidelines.
Yeah,
So
yeah.
at this point of time, patient becomes grade 2 of CRS.
Yes.
Right? You will give a single dose of Dexa and you will consider tocilizumab both, or see, because this patient dexamethasone was given, tocilizumab was
I
counseled and arranged, but patient started feeling better. BP 110 by 70. Should we still give tocilizumab to this patient?
if the patient has hypertension, I would suggest that tocilizumab would be a better treatment, and rather than just using steroids.
Okay,
And so it's a
Hari.
good so we can
Certainly,
use
No, so
tocilizumab.
if on dexamethasone patient is better, would you add tocilizumab?
it is better to add tocilizumab over here rather than wait for, because it becomes increasing. As I said before, it becomes increasingly important for you to control the CRS to the best possible in whatever way you can, because that can sometimes snowball into things which are more detrimental.
And if we would not have started Dexa, like Srinath said, Hari would have preferred Tosi over Dexa or Dexa over Tosi?
Definitely, Tosi. In
Tosi
grade
over.
2, always Tosi. Yeah.
Oh, Reena ma'am?
Generally, what we follow that we use dexamethasone as a pre-medication for before at least first dose of teclistamab. or a bispecific antibody. That's what I follow. So generally, if the patient developing fever and is getting this hypotension, then I would suggest to use tocilizumab.
Tocilizumab. Okay, fine, fair enough. Reena ma'am, any other suggestion? This patient Toci was not given.
Yeah, I think earlier we were not giving it, but now everybody believes that, don't take a chance. And the reason for that not taking a chance is exactly what Hari was saying, that if you don't control your CRS well, then the chances of ICANS and non-ICAN neurological manifestations are very high. So, you're not only controlling this problem, you are also preempting that the other problems with the BCMA molecules don't happen. So it is a good idea to control the CRS as effectively and as early as you can.
I think you all have answered future going. So Tosi was not given. Day 10, patient's relative complained that patient had staring spells lasting for few seconds, 3 to 4 times, and then stopped. I score was 9. Counting backwards, some small issue was noticed between 80 and 60. He got confused. EG was okay, no more spells. Hari, what next?
So this is certainly features of ICANS. I mean, yeah, ICANS, and I would start with giving steroids over here.
No, so here
Because,
I can Hari. Will it be what? What grade?
oh, this would be the starting of grade 2 actually. Yeah, over here.
The Caesar
And
will absent spells or the staring looks you would always consider as Caesar, because if no Caesar,
not
grade
seizure,
2, if
not seizure,
Caesar
but
is grade 3.
these are early features of ICANS. Yeah, these are the
Okay.
early features of things. They are early features of ICANS, and they snowball very quickly into grade 2 unless intervened.
Okay. And what would you do here?
I would start with steroids. I would start with steroids over here in the first place.
So start with steroid, but now no tocilizumab, right?
Not just now, no steroids. First start with steroids and ICANS.
Start
Because
with
if you, as I
steroids.
told you in the beginning, if you
Correct.
use tocilizumab in the background of even some element of CRS over here, it will actually aggravate the ICANS.
Right. Srinath, what grade would you take this absent spells? Srinath?
Okay,
Reena ma'am.
put it
Huh.
in grade 1 and grade 2 because by the ICE scoring, he doesn't go into grade 2.
Correct.
The very fact that you know that this is going to be seizures if you don't start treatment, and you won't now wait for anti-epileptic treatment. So it will be at the borderline, and it is better to start the therapy like Hari has said.
Perfect. So levetiracetam, 750 mg every 12 hourly with dexamethasone was given every 8 hourly. Patient stabilized after that. Hari, will you do rechallenge, and what stage?
Rechallenge with DEXA, you mean to say?
With teclistamab.
I would wait for the thing to resolve before restarting, because generally, if you restart, it's not likely that it is going to. But if the time taken for recovery is prolonged, then you'll go down to a lower dose to start with the teclistamab.
Okay, fine. So it is not that you will stop the drug because patient
No,
has
no.
CRS follows by ICANS. So that is one thing which I learned from this, that you're not just supposed to stop the drug. There is a rechallenge proper table and one should follow that. Reena ma'am, would you rechallenge all these patients?
Yeah, I would, but I would take a little more time. So instead of giving it after a week, I would wait till they actually stabilize and
Yes.
then challenge.
Perfect. I had yes, ma'am. Sorry.
No,
No.
the thing that the mantra is that longer it takes to resolve, the more important for you to start with a lower dose. But if the resolution is faster, then you may just still rechallenge with the existing dose. Yeah.
Absolutely. I think we discussed about hypogammaglobulinemia. Hari, very quickly, I have 3 more minutes, 2 more minutes, sorry, not three. Does CRS and ICANS behave differently with bites versus CAR-T? What we read was bites have less grade 3-4 side effects compared to CAR. Does it change the way we manage CRS and ICANS, or management remains the same? Hari, quick,
Management,
1 minute from you.
management remains the same, and I don't think the cause. It all depends also upon the load of the disease that we are dealing with. Many a time we see that if there's a higher load, you have a. So it is all about anticipation of these things, recognizing it earlier, but you don't treat it differently. You don't treat it differently.
And do they have a different way of presentation, bites versus car, Hari?
Not really, but in bites you can even have delayed CRS that is happening. Most of the time, the CRS associated with CAR T cells are more immediate.
Okay, Hari, you have the experience. I read the ulta that because bites they will give within days CRS and CAR T will take little longer time. But you have a lot of experience with CAR, so that is because the bites they say that will happen in 2-3 days time, maximum up to 7 days. CAR may happen in the second and third week also.
Yeah. Okay.
Perfect.
That's it.
So, Reena ma'am, have you seen a difference, or Dr. Srinath, if you are back, have you seen any difference in the car and bites CRS and ICANS?
So my experience with cars is very minimal. I have used only for 2 patients so far, and that is not even for myeloma. And both of these patients had developed CRS. And what I see, the CRS is little bit more with the car compared to bites. That's what I would only say at this point. Sorry, sir has a much more
So,
experience
so,
than me.
so I'll just say this that because bites is a more sustained therapy, that's the reason why you are likely to. When we give CAR T cell therapy, if you look at the pharmacokinetics of the drug, and if you have paid attention to the presentation, you see initial expansion of the CAR within the first 6 to 7 days of therapy, and in the next 2-3 weeks, it just rapidly decline, and you hardly see any CAR T cells after day 20, anytime after day 28. So the chances of so you're right in saying that maybe you don't encounter too much of CRS in a delayed fashion in CAR T cell. That's the reason why I said over there. But BCMA is something that you administer repeatedly, and so you can encounter CRS at various times, but it's very rare to encounter CRS once the initial dosing has been completed with bites.
Perfect. I think I'm closing this panel because we are at 8:13. Thank you, Reena ma'am. I think I have overshot, but I will
Can I
be
ask
careful
just
next time.
one practical question for all the panelists, if the
Yes,
time
please.
permits?
Go ahead, go
Yeah,
ahead.
Now we are
so right
starting the
now,
audience questions, so you can ask there, and Dr. Anupama can take over.
okay, sure.
Yeah, thank you, Amish. We have 2 minutes left. So first of all, thank you to all. Can you hear me?
Yes, Anupama.
Yes.
Clear.
Yeah. So thank you to all the three presenters for fantastic presentations, and for Amish for as usual conducting a very practically oriented panel discussion. So we don't have any questions from the audience. I have 3 questions. If I have 2 minutes, I'll ask only 2 of them. So my first question is to Hari, and pardon my ignorance here, but why does tocilizumab aggravate ICANS if it is given
Oh,
in that setting?
that's because it blocks the receptors, and so the IL-6 becomes more. It's actually, if you see, when you give tocilizumab, it blocks the receptor. It's the IL-9 receptor. It blocks. So there is higher amount of IL-9 in circulation, which crosses the blood-brain barrier and goes and affects the CNS. That's the
Okay.
reason.
Thank you.
But
And
also,
one
So
question.
that's also a reason why you should not you use the IL-6 level after tocilizumab to determine whether the patient has CRS.
NCCN guideline also first time when I saw Anupama, I was also surprised कि ICANS में कहीं टोसी का नाम ही नहीं है, CRS में सब जगह पे है. So I was waiting for Professor Hari sir's answer.
You're right.
Okay. My second
Yeah.
is more like a comment, but also we can get some insights to Dr. Srinath. Because in your first three cases, you have actually used teclistamab more like a bridge to transplant. So I have no experience with either of these drugs, but whatever reading I have done in the last 2 weeks, It is mostly in penta-refractory patients, triple lines of therapy failed. But you have used it in second line, third line, and used it like a bridge to transplant. Because when we usually say that, okay, it's very long therapy, there is no end point, it's unlimited cost. But you have used a very smart strategy where you've given it for a few weeks, got the patient into a deep CR, and then taken up for transplant. So, would any of the other experts here would like to comment on that? Like, would that be a strategy to be considered?
For me, a patient who has received teclistamab is already well into the treatment, and perhaps they may not be candidates for a transplant itself over there. So there may be challenges with harvesting, but the areas where teclistamab has been used is mainly in the double refractory or even triple refractory disease, and I would say that doing a transplant in those patients may not yield the kind of responses that we desire, which we have to encounter with a transplant. So um, I would hesitate in using transplant as an option in these set of patients.
No, that's not exactly what I'm saying. But he's used it in second line, induced a deep remission,
Yeah.
and then taken them for transplant. That's why I
Yes,
asked.
yes,
I
yes.
understand when
I'm
you have
not very
heavily
sure whether to call
pre-treated
it as
patients,
a
you would know.
double refractive, triple refractive, but all of these patients were triple crust exposed, and those were all patients were young. I do not know how long to continue this teclistamab, and the practical option that was in front of me. And so far, I have been lucky, and so far the data yet to see. All these
Interesting.
patients are recently undergone
No,
treatment.
I'm actually congratulating you that you used this strategy and your patients went to transplant and probably are doing well.
Yeah.
So just something to think about.
And so
And
far,
my
I
last
did not have
question,
any problem harvesting. Yeah.
yeah.
No, there
So my
there
last
wouldn't be, because
question
you're
open to
not having
everybody.
any stem cell toxicity when we use BCMA
Yes.
directed therapy, isn't it? So I think it's an interesting strategy. But again, when you're using CAR T cells in a patient BCMA, for all of us who use BCMA targeted therapy, we know what a challenge it is with immunity and infection.
My final question. Do you see it coming as first line therapy in the near future? Or no, it will
It is
always remain second and third line?
No, it is already come in. I thought the data from Dimopoulos has used, but that was using Tecli and
Phase two first line,
yeah,
I think
yeah,
phase two
first line
first
therapy.
line are
Yeah,
already being
it's
reported
already being
by
used.
TikTok. Yeah, yeah.
So I was privy to some of the discussion where they're using a total therapy, looking at myeloma cure as the thing, and in that they are actually looking at using bispecifics or CAR T cells in combination with monoclonal antibodies and frontline therapy to try and induce the kind of depth of responses over there. And the rationale for that is that you are going to take care of the clones more profoundly, and you may sort of avoid the clonal evolution or molecular progression in these cells, thereby being able to potentially get a cure in myeloma.
Anupama, we have a
Okay.
question in the chat box now.
Yes, there is a question which says with CAR T, the participant size in the Sehat study is around 10 to 15 participants, while other BCMA targeted therapies like bispecific and ADCs, the participant size is 300 plus in trials. So, how can a judgment be made when considering either regimen results? Because I know cross trial comparison is used with caution.
No, it's not. It's not at all a comparison at all. It is just two modalities of targeting the BCMA therapy. The advantage, if at all, you can say for a CAR T cell therapy is that it's a one-time treatment, and you either get the disease under control or you don't. And the other aspect is that the concept of sequencing therapy comes into play right now. So when we are talking about using CAR T cells, BCMA targeted therapy, you would prefer to implement CAR T cell therapy before you would want to consider a bispecific, because if we were to use a bispecific, the loss of the BCMA is more profound because it is used more the same. But when we use a relapse in a CAR T cell, post CAR T cell still may retain some BCMA expression, which can be exploited for a BiTE cell. So a BiTE can never, a BiTE can salvage a CAR T cell failure, but a CAR T cell cannot salvage a BiTE failure most of the time. Yes.
Okay. Anybody else has any questions from the audience? If not, we have crossed our time limit, and
I'll
I'll
just
take
ask
this
one
opportunity.
question if time permits.
Yes, please go ahead.
Yeah. So my question to Reena madam, in your paper you have used elranatamab and teclistamab as both. So how did you choose the patient between elranatamab and teclistamab? Because both the
No,
antibodies soon are going to available in for us.
yeah,
So how to sequence?
no, ours was very simply a compassionate access program, and we got the drugs free for our patients. And we started very early in 2023. And so many of the mistakes that we made, we wanted to highlight in this paper because now many people are going to give these drugs. So everything that you said, vaccination is very important. Don't forget it before you start these patients. Use immunoglobulins generously. For us, we had patients who could not even afford the IgG level, forget getting IVIG. But this is something that we must consider. We didn't see too much of CRS, so we got away without having TOSI for most of these patients. It was the drug that was available on compassionate ground, which was given. So initially, our data is with elranatamab, and that is when we were not giving IVIG. Preventive or preemptive IVIG was given to all patients who were on teclistamab, and we saw much less infections, and definitely the mortality was on the first treatment that we used rather than on the second. So there is no choosing. It is we just were getting experience out of it, and this is our experience.
So if I may
Okay,
just
ma'am.
add to that, now that you have a more mature data for elranatamab and teclistamab, if you will see there's barely any sunlight between the curves, but you can't
Yeah.
have cross-trial comparison over there. But if I were to say if there is any advantage of elranatamab is that it is fixed dosing, and you have a fixed dosing schedule over there, and you can rapidly migrate to once in 2 weeks schedule with elranatamab. So in terms of using it more logically over there, and in terms of being able to decrease sometimes toxicity, maybe an advantage. But in terms of responses, I don't think there's anything else much to choose between the two.
Yeah, with very few patients, we felt the kind of PFS that we got is very much like the one that is reported in literature. We, of course, every patient is 10%, and so when you look at 20% mortality, it's 2 out of the 9. But it taught us many lessons, and we did become careful. And of course, we had the advantage of both the SWAST trial for CAR T, and we had a large number of other trials which came up, phase 4 as well as phase 3 with BiTEs. And so now the experience in that institute is far more than what it was when I left from there. So, Upama, you want to wind up? Thank you so much.
Yes, so thank you to all the three speakers and Dr. Amish for a very practical case discussion with problems that we actually encounter in practice. And thank you, audience, for attending and giving inspiration to the speakers. I will wind up the session here. Good night.
Thank
Thank
you.
you.
Thank you. Thank you.
Today's academic session, I would like to extend my heartfelt gratitude to our esteemed program director, distinguished speakers, moderators, panelists and delegates, and participants for their valuable contribution and active participation. On behalf of the International Association for Integrated Oncology, thank you all for joining us. We look forward to welcome you again to our upcoming IAIO academic programs. Have a wonderful evening. Thank you. Stay safe. Good night, everyone.
Thank you. Thank you.
Thank
Thank
you.
you very much.